Hi, everyone, and welcome. Um, Happy Tuesday. My name is Scott Allen. I am the CEO for the Family Medicine Education Consortium, and I'm excited that you joined us tonight for
Sorry.
a session that we're calling a virtual showcase. It says hot topics on the screen, but that's what we called them last year in case you participated in them last year. But this is a way that the Family Medicine Education Consortium can help students and others who are interested learn a little bit more about some of the family medicine residency training programs in the Northeast US. So tonight we have the Maine Dartmouth Family Medicine Residency Training Program, and I'm going to turn it over to Dr. LaFave in just a minute. But first, I want to just make sure everyone knows who the FMEC is. So if you are not aware of us, we are a Northeast regional group of medical schools and family medicine residency training programs. We cover 14 states and DC in the Northeast US. It's about 60 medical schools and 190 family medicine residency training programs in the region. We do an annual meeting each fall. Our next meeting is in October in Providence, Rhode Island, and we bring about 300 medical students to the meeting on scholarship so that they can learn about family medicine and meet with residency programs at our residency fair, which right now has 81 programs for this year, and we hope that'll go up just a little bit in the next month or so. We also do a series of awards for both career accomplishments, but also for things like creative writing and art. We do some learning collaboratives. We have one right now going on around hereditary breast cancer and using narrative medicine. And we have some committees and some other opportunities for people to get involved in the FMEC. We like to consider ourselves a catalyst and convener, helping programs connect across the region and helping medical students connect to residency programs and helping residents connect with each other. We really have three main goals, which is to promote family medicine to medical students and encourage them to choose that for their specialty, to connect, to improve the experience of family medicine residents by giving them additional opportunities for outlets for scholarly work, and helping residency programs themselves do as best they can in training, helping them meet new guidelines and things like that. So please join us if you're not already planning to. We have an annual meeting in October this year at Providence, Rhode Island, October 13th through the 15th. And our next year's meeting is in Philadelphia, September 19th through the 21st. If you're in our region, you're welcome to apply for a scholarship. If you're not in our region, there are other ways to attend, and I'm happy to answer questions about that afterwards or offline. So with that, I'm going to turn it over to Dr. LaFave.
Hi, everyone. As Scott mentioned, my name is Caroline LaFave. I am on the faculty at the Maine Dartmouth Family Medicine Residency. We are based in Augusta and Waterville, Maine, which is kind of the middle of Maine. We are a full spectrum program. We are an unopposed community-based program. And one of our big strengths is we do a lot of obstetrics and reproductive health care. We do lots of other things really excellently too, but those are two things that are my passions in medicine. I went into family medicine, or I went to med school thinking I wanted to be a pediatrician. I wanted to do nothing else until I did my clinical rotations, and then I really loved delivering babies too. And so, because there's not an OB-PEDS residency, family medicine was the best thing. And I really love that I get to take care of family units across the spectrum of ages and really do everything from birth to death and in between. I recently had a very busy week as an inpatient attending where I said to someone, it feels like I'm on a board exam for the entire week because every aspect of my family medicine knowledge is being tested. I delivered a baby, managed obstetric complications, did end of life care, took care of pneumonia, answered questions about outpatient things. So there really are ways to do all the things that we talk about and love in family medicine. So tonight I'm going to talk a little bit about contraception. I first did I've given this talk a few times. These slides are from when I talked about in the postpartum period specifically, and why it's important to do it and what options exist. So that's why some of the slides are more geared that way. I have no financial conflicts of interest of any kind. So I may use brand names for some of the things, but that's because they're easier to say than the generics. And then I also, not everyone who can have a baby identifies as a woman, but I may use women in that standpoint. So I'm going to share my slides. Okay. And then Uh-oh. Sorry, hang on one second, guys. Me too. All right, can you guys see that now? Great. Okay. So birth control options. So particularly important in the postpartum visit, because probably about 40% of women or more have unprotected intercourse before that 6-week visit. We know for women that are not breastfeeding, ovulation can occur within that time period. Usually it's within the first 3 months. And then they're certainly at risk for short interval pregnancy, which means a short interval pregnancy, which is where baby to baby is 18 months or less. And those come with all kinds of complications, can put you at risk for preterm delivery and other complications such as that. So the current recommendations are that pregnancies be at least 18 months apart. If they're closer than 6 months, there is increased risk of preterm birth, low birth weight, and small for gestational age. So that's if from when the baby was born to when you get pregnant again is less than 6 months. And then 6 to 17 months or longer than 60 months also have other risk for those outcomes. But not as much as when they're that close together. It's also if you happen to have a C-section, having a short interval pregnancy does have a reduced success rate for VBACs. You also have to take into account having 2 small children under that age puts a lot of stress on families, social support systems. And so talking about contraception at every OB visit is helpful for this. I am a huge advocate as we provide the full range of all contraceptive options and understanding how that plays into the context of their lives and also understand we don't want to coerce anybody into making a decision. There are so many choices. There's so many places to start. There's a great resource. I'm going to hold up what I have and I think you can request these handouts. So this is from a group called Upstream that wanted to create a contraception counseling handouts that were like non-coercive in any way. So they have this great pregnancy wheel. I think you can probably order them. I don't know if they'll be at Smec, but they're pretty awesome. And so this shows how effective they are and then has all the different side effects, effectiveness, other things to think about as you turn it around. And then on the back side, so this is medication forms of contraception and then non-medication on the back. So that's a pretty cool thing. So Upstream is the company that makes that. So there's so many choices. I usually start counseling people with the success rate. So certainly if you just go by chance, about 85% of people will get pregnant within a year. So that's just like not doing anything, like not counting days, not doing anything, about 85% of people that can get pregnant well. Something that is more effective than that, but still not great, is condoms. And so that's kind of the typical use that people use, about 14% effective. If you use them perfectly every single time, it's about 3%. Pills, patches, and the NuvaRing are about 8%. IUDs are much more effective. Then the injectable form is like a depot injection. The implant or Nexplanon, also very effective. And then tubal ligation or vasectomy is equally as effective. So how do you choose? The first question I always ask is, what does the patient want? They may want hormones. They may not want hormones. They may not want anything in their body. They may be totally undecided. They may not be able to take a pill every day. So those are all things that you want to think about when you're having this conversation. This handout is from the Reproductive Health Access Project, which is an excellent website Their focus is on contraceptives, miscarriage management, and abortion counseling, or like pregnancy decision making. All of their handouts are very inclusive. They're not coercive. They're just really great. I use these all the time in clinic to talk to people about what their options are. I'm our medical director for Colby College, which is right down the road from where we are. And so I do lots of contraception in that setting, and I use this handout all the time. What I like about it, it tells you how you use it, if there's any impact on bleeding or periods, other things to know, and then how well it works. So you can really see the difference between those two. So this is how you access it. That's the website, is just reproductiveaccess.org. And if you go to resources, there's this birth control choices fact sheet. The other really great website is called bedsider.org. So I sometimes tell people the reproductive health access is like the textbook, and Bedsider is kind of the glossy magazine version of it. So there's a lot of patient stories and how they use it and questions. So it's just it's like a magazine version. So the first thing you want to do when you're talking to patients about what they want, if they're open to anything, you want to do a medical history screening. Are there any contraindications to having one type? And often that's contraindications in terms of hormones that they're taking. It's important to check their blood pressure. That can be a contraindication for lots of different ones. And then there used to be a thought that you have to do a physical exam, a PAP, STI screening. Those are not required to prescribe contraception, but you want to think about doing them for other reasons, right? If they're sexually active, you should think about screening them for STDs. You should think about doing a PAP, but if they're not due for it, you don't have to require that. And patients are allowed to decline those services as well. So then you want to talk about, is it safe? So the way that we can find, or the way that the CDC is defined safety, so this is MEC, stands for medical eligibility criteria, and there's 4 categories. So 1 is it's safe, nothing different. 2 would be that the advantages of the method outweigh the risks. 3 is that there are probably some risks and you want to think about doing something else. And 4 is there a real, very much real strong risk to using that form of contraception and you don't want to prescribe it. So this is what the summary looks like. This is straight from the CDC website. There are lots of great apps you can use at the end of this to look up for various medical conditions that people have. So at the top, CHC stands for combined hormonal contraceptives. So those are your, like the most common when people talk about taking birth control pills, those are often that. It has estrogen and progesterone in it. Then you have progesterone only pills, the injection, which is Depo-Provera, which is progesterone. The implant, which is the next one on, that is also only progesterone. The levonorgestrel IUD, which is just a progesterone, and then a copper IUD. And then on the side here, then you have the conditions that somebody could have. So, for instance, someone with current breast cancer, you would not want to give anything with the hormone, right? Because those hormones can cause the cancer to grow. So the only option would be a non-hormonal form, which would be the copper IUD. Breastfeeding, thinking about this in terms of the postpartum period. In the first month postpartum, we typically don't prescribe combined birth control pills because your risk of clot is elevated in that period anyways, and the estrogen part of the pill can also increase that. So that would be an example of why that's a 3 and not a 1 or a 2. After that 6 weeks, or it's usually like 3 to 6 weeks after that point, it's safer. Okay. Then there are LARC options. So LARC stands for long-acting reversible contraception. So in the postpartum period, you can put in IUDs immediately after the placenta delivers. So usually you have to do it within the first 10 minutes, or you do it at the 6-week follow-up. Doing it immediately after the placenta is great. If someone has an epidural, like they have pain management, it's easy to put it in. You don't have to dilate their cervix. It just goes in, stays there, and they're covered for birth control immediately after birth. There is a greater risk that it falls out. So it's about 25% of those post-placental IUDs will come out. If you do it at the 6-week follow-up or just your general IUDs you put in, there is a risk of the risk of them coming out is somewhere between like 1 and 7% over the course of the 5 or 8 years that you have it in. Nexplanon also great. You can put them in anytime, no matter what they're doing. And they're progesterone only. Okay. I think I have a slide later on where I talk about that. So your IUD options, there's a copper IUD and then there's levonorgestrel IUDs. So the Skyla and Kylena are a little bit smaller. They have slightly less hormone. The Mirena, Liletta, and is there one other name for it? Those are the 2 brand names, are a little bit bigger and have slightly more hormone in them. So the Paragard is good for 12 years. The Skyla and Kylena are good for 3 and 5 years respectively. And then the Mirena or Liletta are good for 8 years now for birth control. My computer is freezing. I've asked it to do too many things today. So I'll talk a little bit about the hormones and IUDs versus pills. So the 2 hormones that control your cycle, so a menstrual cycle, are estrogen and progesterone. Estrogen is what causes the lining of the uterus to build up, and progesterone is what causes it to shed. So you see a spike in estrogen. Oh, now it's working. Spike in estrogen around the time of ovulation, and then when the egg doesn't implant, it drops, and then progesterone comes up to cause the lining of the uterus to shed. One of the OBGYNs we works with likes to talk about estrogen as the fertilizer and progesterone as the lawnmower. And so if you use that to think about why you get side effects with any of these, the most common side effect we hear with any LARC is consistent bleeding or irregular bleeding. And the reason behind that, if you have progesterone that's constantly stimulating the lining of the uterus to shed, you can get spotting. At some point, there is no more lining of the uterus to build up, so the spotting usually stops somewhere between 3 to 6 months. All right, I'm going to stop sharing and see if I can get PowerPoint to work again. I'm so sorry. I can't say I have had it quit in the middle of a slideshow before, so let me get back where I was. How about while it's working, does anyone have any questions to this point? No? Has everyone heard this before? Well familiar with LARCs? I didn't get some of the things that people tend to have more questions about are pills.
Actually, I was wondering, is there like a big cost difference that matters for these contraception options?
There can be. There shouldn't be any more. So when they pass the Affordable Care Act, all contraception should be covered by all insurances. I often tell people usually have to pay for the procedure visit, like the visit charge, but then the device itself is covered. If you were to go and work in a low income country, the Liletta is the newer one. That one is significantly cheaper than the Mirena. It has a slightly different insertion device. So it just has like a different way of doing it. So if you watch the video for how to put in a Liletta, the steps to get to the point of inserting the IUD are the same. It's just the thing that you use to actually put it into the uterus is different. I don't know why it's having such trouble to keep PowerPoint open.
Hi, I do have a question too.
Yeah.
Hi, I'm Jyotin, and thank you for such a nice presentation.
Yeah.
My question is that you said that hormones should not be given as contraception during active breast cancer. But what about like if the breast cancer is in remission, but it is like hormone sensitive breast cancer, will it be still contraindicated even when the person is in remission?
I'm gonna look at the chart. Oh, it is really not wanting to work there. I can show you guys. So my favorite app that I use is the app is called Contraception. It is developed by a family practice doctor. His name is Josh Steinberg. He's a great guy that does a lot of OB stuff, but has a great app for it. And so the whole MEC criteria is all on there that you can pick by it. All right, I'm going to try and go back to that slide where I look at the MEC. But basically, if they're, you can compare the two. Okay, so if you look at this side where it says breast disease, so you have undiagnosed mass, it's a 2 because if you don't know what it is, you wouldn't know what to give them. Benign breast disease, family history of cancer, fine to take hormones. Breast cancer, if it's a current active cancer, it would be a 4. And then if it's a past or no evidence of current disease for 5 years, it would technically be a 3. So you could consider doing a hormonal contraceptive, but the one that is recommended would be the copper IUD or a surgical option, like if they're really done having kids, thinking about a tubal ligation or a vasectomy for that person's partner. All right, I'm going to try and get back to the slide I was on. Which it doesn't want to go to. Okay, can people see that now? It's on that slide. Okay, so these are the comparison between the four kinds of IUDs. The mechanism of the copper IUD, it interferes with sperm motility, and it makes it like a inhospitable place for an egg to implant. So really it's just having the device by itself prevents pregnancy. The biggest side effect we see with the copper IUD, it can cause really heavy bleeding. And so I actually end up taking more of them out than I put in because of that side effect. But there are plenty of people out there that want a non-hormonal IUD that do great with the copper one. For the hormonal IUD, it thickens the cervical mucus, which can act as a barrier for sperm, and then it also causes a thinning of the uterine lining, so it makes it harder for an egg to implant. Things to know. So the different doses of the IUDs, so the Mirena and Liletta, or the higher dose, which is this 52 milligram. Like I mentioned before, spotting, bleeding, cramping, common in the first 3 months. Also really common that you get no period. I have just as many adolescent people being worried about that as a side effect and worried they're pregnant, but it's a great side effect as well. And then there is that chance of it falling out about 2 to 12% in that first year. Very, very low risk of perforation at the time that you put the IUD in, so that it would be where you go through the uterine wall. I have to remind, when I'm teaching residents how to do it, it is pretty gosh darn hard to push hard enough to actually perforate the uterine wall if there's not already a defect there. Things you would want to be cautious about: someone who just had a C-section may have a thinner wall, or like a window we talked about. That's where you want to be careful. But you know, if and when you scrub into C-sections, you can see just how thick the lining of the uterus actually is. Headaches and worsening acne can also come along with that. For the slightly lower dose ones, so this is the Skylar Kymena, they tend to be a little bit smaller, and they were specifically created for people that had never had babies before, so nulliparous patients. There is less of a chance of not having a period with that. Only about 6% of people don't have one after a year. And there's no evidence that you actually have lower side effects from the lower dose, but there are plenty of patients who choose that because in their mind they want the lower amount of hormones. Most life-threatening complication will be an ectopic pregnancy. So I always teach people how to find the strings when you put an IUD in and feel for them. And while IUDs do not cause ectopic pregnancy, if someone is to get pregnant while they have an IUD in place, it's much more likely to be an ectopic pregnancy. So if someone has an IUD and they are worried that they are pregnant, you need an urgent ultrasound to make sure that you can find that pregnancy. The implant, this picture, you can't exactly see it, but this is an Explanon. So it's a rod that goes in the arm. It usually goes right here. It's about that long, about 3 centimeters. It has a higher amount of progesterone than any of the IUDs. So it's about 62 milligrams compared to 52 or 13. And that amount of progesterone prevents ovulation, thins the endometrium, and thickens the cervical mucus. So very much works the same way as an IUD, just a higher dose because it's circulating within your body. Lots of people choose it because they don't want a pelvic exam or don't want something inside of them. It's also really easy to put in, and it's equally effective for people at whatever BMI they're at. This is one that irregular bleeding is one of the more common side effects. So the ones I've taken out, people often complain about bleeding risk. So that's all about LARCs, which are the most effective form of birth control we have, save for tubal ligations or vasectomies. Our oral contraception and non-LARC options. So OCPs, there are tons of them. Like I said, they are estrogen, progesterone, or progesterone only. All of them increase the risk of blood clot, stroke, and heart attack, but the risk of those is much lower than if you were to get pregnant. Pregnancy is actually a very, increases your risk of all kinds of things. So the only absolute contraindications for combination OCPs, so the ones that have both estrogen and progesterone, are migraine with aura, uncontrolled hypertension, being postpartum less than 21 days, history of a DVT, and then if you were smoke and you're over the age of 35. And then active breast cancer as well. But when I am doing my history of someone in the office, those are the things that I ask most commonly about. So if they're a smoker over the age of 35, I'm really hesitant to prescribe a combination birth control pill. The other question I get asked a lot, especially prescribing these in the college population, are what medical interactions do you have to worry about? Does anyone know what is the kind of common thing we tell people, like, if you take this drug, it'll make your birth control less effective?
Antibiotics?
Yes, antibiotics. So we counsel patients about that all the time. but there's actually very few that make contraception less effective. So it's really just rifampin, and then some of the antivirals and anticonvulsants. So all the other antibiotics, amoxicillin, penicillin, ceftonir, doxycycline, things like that, that we often prescribe to sexually active people for various infections they may get, are perfectly fine to interact with oral contraceptive pills. So how do you choose which pill to start people on? If you try and enter, you can't just enter like birth control pill in the EMR. I wish there was an easy way to do that. You have to choose a type of estrogen and then choose a type of progesterone. It's a good idea to have like one brand name that you know, so it's easy to search for when you're ordering a medication in different classes and which ones you use. So there are doses of estrogen. So there's low, medium, and high, and then there are classes of progesterone. So first, second, third, and fourth generation of those. They really are mostly the same. There's lots of marketing at which ones are more effective than others or have less side effects or something. Some pills have an iron pill that you take during the placebo week. There is monophasic and triphasic. So if you look, the pill that's on the top where the pills are the different color is one of the triphasics. And that is, there are different amounts of estrogen in each of those to more mimic like what a natural hormonal cycle would be. They don't work any better than any other. So how do I order it? So this is a screenshot from that app that Scott shared the link to. But I look at, this has the estrogen amount and the progesterone amount, and then listed by generation. So I usually start a middle dose of both. And kind of my go-to that is covered by almost all insurances or is on the $10 list at a lot of pharmacies. So as you guys get into practice, you'll find in patients that don't have insurance or really bad insurance, there are plenty of pharmacies that have coupon programs that have, it's $4 for a month or $10 for 3 months. And so Sprintech down here is your orthotricycline, or Sprintech is a kind of a medium dose of both of those. And it's a 3rd generation progesterone. I typically write for 3 months at a time with 3 refills, so a whole year's worth. That way, patients can skip a period if they want to. If they're going on vacation, they don't want to have it, that is perfectly fine to do that. So other options beyond pills. So there are actually other types of pills. The other one that I prescribe a lot is Yasmin. Yasmin is a 4th generation progesterone, which has more adrenicity effects. So that adrenicity is most helpful for acne. So you think about teenage patients that are starting an OCP that have bad acne, starting them on Yasmin, or the drospirenone is a good one to do for that. There's also progesterone only pills. So those have no estrogen, just progesterone. So that would be like this Camilla or Micronor is one of that. Within the app I mentioned, there is that great table to look at. And actually it's been updated since, I think it was just updated a couple of weeks ago or something. So the table looks a little bit different, but it's the most up-to-date information. So other options for birth control, there are patches and NuvaRing. And like I said, they both have estrogen, so you want to avoid them in the first 3 to 6 weeks postpartum, but can be great options for people that don't want to take a pill every day, but don't want a long-acting contraception. So with the patch, you change that every week and then take it off for that placebo week. And then the NuvaRing, you can leave in for 3 weeks at a time, then take it out. There are some that you can actually leave in for a year. So I often describe those to patients. It's kind of like the menstrual cups that are becoming more popular. They're really flexible, and they're just inserted into the vagina and kind of sit around the cervix. You shouldn't feel them. Your partner shouldn't feel them. They just sit there. I've actually done speculum exams on patients that have them in, and sometimes I see them, sometimes I don't. They're like very much just stay there. When you prescribe any of those things, you want to counsel what do you do if you miss a pill, the warning signs to watch for. So like clot being the biggest risk, like when you would want to call them, and then what to expect for changes in periods. The Reproductive Health Access website has some really great handouts about like how you skip pills or what to do if you miss a pill. That's helpful when you prescribe them. So these are the two apps that I use. So the MEC app is the CDC one, that's to get that table. It is built into that contraception point of care, which I believe is I'm pretty sure it's a free app. And if it's not free, it's like 99 cents or something. So I would highly recommend that if you are going to be prescribing birth control to anybody, which is pretty much all family doctors at some point. There's also emergency contraception. And there is, especially in light of Supreme Court rulings where abortions aren't legal in many states now, emergency contraception, you may get asked more often to prescribe that or know how to prescribe it. So there are really three that are considered emergency contraception. There's Plan B, which is available over the counter. So you can walk into any pharmacy and request that from the pharmacist. It's effective 5 days after unprotected sex, but it loses efficacy for patients with a BMI over 26, and it decreases in efficacy from the time from unprotected sex. The other pill that is available is called Ella. It is more effective. It's more effective for a longer period of time, and it's more effective for patients at a higher BMI, so up to 35. And then a copper IUD is the most effective, and that can be placed up to 5 days postpartum. I'm almost certain there are newer guidelines out this month that actually the hormonal IUDs can be considered emergency contraception, but don't quote me on that. It is not not everywhere is doing that quite yet. But that was a relatively new recommendation. Ella, you need a prescription for, like I said, Plan B, you don't. Plan B is much cheaper. And so with GoodRx, Plan B is about $13. Ella is closer to like 20 to 30 with GoodRx. Sorry, 42 without insurance there. At the clinic site I work at, Maine Dartmouth, we have IUDs and Nexplanon stocked in our office. So if someone walks in on any given day, we can put one in at that moment. So someone comes in, they find out they're pregnant, or they had unprotected sex with the last 5 days and they want a copper IUD, we can do it right there. Planned Parenthood definitely does that too, but it's really nice to offer that within our clinic. There is also, people may hear that emergency contraception induces abortion. That's not how it works. The way that it works is it inhibits the implantation of the egg. So even for some reason it would be fertilized. If it's that easy, it wouldn't implant. So it's not causing an abortion. It's not doing that. It's just affecting the lining of the uterus. Questions people have?
I just wanted to clarify, is it just the age over 35 which is absolute contradiction, or is it age over 35 plus tobacco use or those things?
It is age over 35 plus tobacco use.
Okay, yeah.
And it's purely from the risk of clots is so the estrogen is the component that increases your risk of DVT or clots. Smoking tobacco increases your risk of DVTs alone, and then being over the age of 35 does as well. So there are like having those three things, it's really like a significantly higher risk. That being said, I have transgender patients that are on estrogen that smoke that are inactive that I still prescribe it for, and I counsel them of like, you're at significantly higher risk of a clot. If you ever have pain in your leg, I want you to call me. Or if you're going on a long car trip, like you consider yourself as being likely to develop a DVT and you have to move around more often. So it's all about counseling. It doesn't mean you absolutely can't. It just means you need to have that conversation about what those risks are with the patient.
Thank you.
Yeah. And then the migraines with aura, birth control pills can make migraines worse. The estrogen and progesterones in it can do that. And the aura, like that specific component that causes headaches, can really exacerbate those types of migraines with the estrogen component. Other ones just that are interesting on here. So bariatric surgery, if you have bariatric surgery, that's a malabsorptive procedure. So that would be like a Roux-en-Y that you really aren't absorbing anything. Those are contraindicated more, like you're just not going to absorb the hormone. It won't be as effective in those. Other ones, hypertension, we talked a little bit about, and so it's really just based on what your blood pressure is. Birth control pills can make blood pressure problems worse. So that's one I often screen for. And here is your whole, oh, you guys probably can't see my cursor moving around, but the DVT, PE, the ones that are all 4s there are really like if you have a higher risk, like you have a history of one, you're not on an anticoagulant and you're at higher risk for having one again. So I will say like 3 months into my residency, one of my patients had a PE. She was on birth control pills driving back from Florida to Maine and was a smoker. So she was the classic picture of someone who had every risk factor of having a PE. So she is now on a blood thinner. She is no longer on birth control pills and she's quit smoking. So it was great. Those are all good things and for her.
Dr. Lefebvre, there's a question in the chat. I don't know if you saw.
Oh, how long do you maintain one birth control method if side effects occur? Mood swings. That's a great question. I often give things at least a month to just see how it is. Like lots of new medications you start, you want to give it a month to see. If after that month it's really intolerable, like they're like, yes, I take this medication and I feel worse on it, I will think about switching to something else. And so that can be changing the class of progesterone, like for some reason they react to that, or increasing the estrogen at a higher or lower dose. So if I had started them at a medium dose, I may drop them to a lower dose or think about a progesterone only pill. The other thing that's really nice in that app I mentioned, and I promise I did not make this app. No one gets paid by me talking about this app. It's just one of the things I use the most. It has like how to choose or adjust a pill based on side effects that people have. So you can look at it. So the estrogen side effects would be nausea and vomiting, bloating, headaches, breast tenderness, weight gain, those types of things. If they're having a lot of those, that would be when you would think about going to a lower dose. And then the ones that are estrogen deficiency side effects would be like having more spotting, vaginal dryness, breakthrough bleeding, that I would think about increasing the dose of estrogen. So it's kind of a nice guide. If someone's complaining about side effects, you do not need to keep someone on for a long period of time to do that. And then the other thing is screening for adrenergic side effects. So those are acne, hirsutism, weight gain, and anxiety. So that could be one to think about changing the progesterone based on that. So it's very nice to break it down that way. The other thing that's helpful in here, often you'll have to switch between methods of they were on a LARC, they wanted it out. You have to figure out, what do I tell them to start on a pill? Like what is their risk of getting pregnant within that? There's a really nice table for what you do if you're switching from one to the other. So if you are, say, switching from, like, someone was on the pill, they come to your office, they want an IUD, you put one in, you would want them to continue the pill for 7 days after you put the IUD in for the most effective birth control, right? Because that 7-day window is like the time that we counsel people that they could still get pregnant. So if you continue the pill for that 7 days, that reduces that chance. Yeah, other things that are helpful in here, there's a whole part about if you miss a pill. The Reproductive Health Access Project website also has some really great handouts that I will print for people when I start them on it. I will also do the same thing. They're like great aftercare instructions for Nexplanons and IUDs. I didn't list anything in here, but the other thing, you won't find these published guidelines anywhere, but I have learned from doing lots of IUDs and working with our midwives and various OB-GYNs. I often, for nulliparous patients, so I do a lot of IUDs for college students. If you prescribe misoprostol to be given either orally or vaginally before they have the IUD placed, it can help soften the cervix and make that easier to dilate. And then I am certainly not adverse if someone is really anxious to giving anti-anxiety medication. Any patient with a penis who has had a vasectomy gets benzos beforehand, and I think it is just fine to give patients benzodiazepines before IUDs if they want them. So prescribing ibuprofen before an IUD insertion, like taking it half an hour before it's placed, can also really help with cramping. Let's see. Other questions, those side effects with IUDs or Nexplanons, the bleeding that happens in that 3 to 6 months. If you have someone who is thinking about getting one of those out, you can trial for that bleeding side effect. So that would be you're having more of an estrogen deficiency, right? Like that constant progesterone load. Giving a course of ibuprofen or naproxen, so an NSAID for 7 days, can actually help stop that cycle of bleeding, and that has to do with the prostaglandin inhibition that happens with those medications. So it's not in this slide set, but there are some nice handouts of how you take that. But basically, it's taking 600 milligrams of ibuprofen 3 times a day for a week can help do that and get someone to keep it in and get through that like 3-month period that you expect that bleeding. There are also people I put on like a 1-month course of birth control pills just because they want to keep the Nexplanon, but can't tolerate the bleeding side effects well. Besides ibuprofen prior to IUDs, are there any current guidelines for pain control during the procedure? They're not guidelines, but there's different practitioners will do things different ways. I did not learn this until I was well into my, actually after I graduated from my residency, but if you can easily dilate someone's cervix, you actually don't need to use a tenaculum. So if anyone has seen an IUD, so it's a speculum exam, We put a tenaculum, which is a pinchy clamp on the cervix to hold it into place, and then use a dilator to open the cervix. And so if you can easily open the cervix, you don't have to use that tenaculum. And if I'm able to do that, a lot of patients tolerate it much better. The procedure goes really fast. It's tends to help with that. Using the misoprostol for patients that have never had babies before can also help. A lot of the pain and discomfort that comes with the procedure is from getting the cervix to dilate. It causes a lot of cramping, discomfort, so that can be helpful. There are also people that there's some practitioners that offer cervical blocks. So that is 2 injections on either side of the cervix into the pudendal nerve that can numb the area, and then you don't feel it. So I don't routinely offer that now, but if I had someone who really wanted an IUD, who was really nervous about it and couldn't tolerate the pain, that is something I would offer. I also, the other kind of sequelae that can sometimes come with doing the IUD is a vagal response. Like the person sits up and they get really nauseous and feel faint and lightheaded. And I know this isn't how it works, but I think about the vagal nerve, which stimulates those feelings, is kind of wrapped around the cervix. And so you can just get a lot of those side effects afterwards. I have Zofran in my office for that reason, and I'll have people sit for a while. Sometimes a snack can help. I know that feels silly, but a snack can help a lot of things. So just anticipating those side effects and talking to people beforehand if they feel that way. Most of those side effects tend to be from patients who have never had babies before. Once you've had a baby, your cervix is dilated before, it's not as hard to have it open again. These are great questions. Does anyone have any questions about the residency too? I spoke a little briefly about what we do at Maine Dartmouth, but happy to talk about anything else there. We do, when we talk about contraception, people often want to hear about abortion training. We do have a longitudinal curriculum for that we offer as well.
What kind of subspecialties does the residency offer?
We have 3 fellowships with that is an extra year after our 3 years of training. So we're a 3-year-long program. We don't have any specific tracks. With the new ACGME requirements that say to practice OB, you have to do 80 deliveries. All of our residents are meeting that criteria now. So our plan is that everyone should graduate able to do deliveries after residency. For the folks who really want to do OB afterwards, it's usually significantly more than that. So when I was a resident, I think I did like 160, but I also had a baby during residency. So I was on OB like every July for 4 years, which is a high time of delivery. So I had a lot, but getting to 100 or 120 is not hard to do. We also right now, because we don't have any other residents in the hospital, we first assist on all emergent or urgent C-sections, which is a lot of great experience. It's most helpful. Like I'm a family doctor now. I don't do C-sections, but I can very well counsel people on what to expect with C-sections, and then helping make the decision about when we do have to go to C-section during labor. So there are no tracks. The 3 fellowships that we have that are in the Maine Dartmouth umbrella, we have a sports medicine fellowship, a neuromuscular / OMM. It's technically a +1 residency, but like an OMM fellowship, and a geriatrics fellowship. Within the Maine General Hospital, there's also an emergency medicine fellowship that is open to family medicine doctors, as well as, I think it's just internal medicine. I don't think they've had anyone who is PEDS trained come and do that fellowship. But that's a good number of our residents will do that. And then after you do that emergency medicine fellowship, often they practice in like rural community hospitals. Big level 1 trauma centers want you to do an emergency medicine residency, but a lot of people practice in slightly smaller hospitals. Yeah.
Hi. So is the program welcoming to IMGs also? And the second question is there a fixed cutoff on the year of graduation, or is it on the case-by-case basis?
We are very friendly to IMGs. Almost every year we match people that went to an international medical school. We are kind of, it's best if you graduated in the last 5 years, but that is not a hard and fast rule. And we have had residents who have been really successful that graduated more time ago than that. There's certainly some level of getting up to speed with systems, right? So the longer you're out of doing rotations, the longer to those systems of using EMRs and stuff. So we do our best to support our residents in that, but I can think of, we have one this year I worked with who just finished his first month of medicine, and that first week was really hard, but after that first week, things you kind of get into the groove of it. But that first week is really hard for everybody. So attendings, residents, nurses. So everyone figuring out how things work and how to get the things they need in the hospital. So
thank you.
Yeah. We have a very robust website as well. So it's just mainedartmouth.org. There's lots of information about our current residents, where they trained, and then lots of frequently asked questions that we just updated. So I can attest that they're accurate. We have 2 minutes. Does anyone have a 2.5-minute question?
Can we have your email address if we
Sure.
want to?
Yeah, I'll put it in the chat.
Thank you.
I feel like this is a very broad question, but what would you be like the ideal qualities that you're looking for in a resident for your program?
That's a great question. And I think this applies to any family medicine program that you apply to. The thing is, I want to hear most from people are, why did you pick family medicine? What excites you about it? And then why did you pick to apply to our program, or what excites you about our program? I certainly have heard cases where, people say like, oh, I want to take care of everybody. And having specific examples of that is great, or like how you want to incorporate that into your future practice. I know the things we imagine for ourselves when we graduate med school are very different than when we graduate residency, are very different than 5 years out. But it's, I always get excited by people that have that thought of like, this is how I want my career to look like. And these are the things that bring me passion in medicine. We can all pick much easier jobs than doing family medicine. It's basically all of medicine that you need to know all the time. And anything could walk in and you never know what it's going to be. It is both the most wonderful and hardest part of this job. So thinking about, are there parts of it that you want to do, and saying that. And then the other advice I would give is spending time on your personal statement. Have lots of different people read it, and really think about answering that question of like, what brings me passion and why do I want to do this? It can be a patient story, it can be a life story. Some of the best ones I've read have nothing to do with medicine, but apply to like their thoughts and values of it. Medicine is a team-based sport. So I also want to ask people, like, how do you work in a team? Like, how do you support your teammates? Maine Dartmouth, the thing that brought me here and that I continue to love is the support I've gotten from everyone in our organization. Like, truly, I can't think of a more supportive job or place I want to be. Like, I tell my husband, as much as I complain about the number of hours I work, I really love the people that I work with, and couldn't imagine doing it anywhere else. So those are questions you should ask yourself as you're applying as well. Like, is this a place that I can be a team member? And like, it's everyone should have boundaries, right? That like, these are the things I do at work. This is my time away from work, but also know like we are in a profession where there are days that like someone always has to be at work, and it is going to be your turn at some point or other. And there are going to be times that you can't be there. And so how are you going to support your teammates when that happens to them? So I often tell my kids always ask like, why do you have to work today? And I always said, I'm like, it's my turn. Like it's someone has to be there all the time. And today is my turn. And they say, why is it always your turn? So, yeah. So I, that is something I want to hear from people of like, this is how I support a team. And that is not to say like, I do not want people that want to work 100 hours a week or think 80 hours is not enough or something. I want people that have boundaries, but also people that understand that what we do is a 24 hours a day job. And it is always somebody's turn to work. So, so I went over by 2 minutes. Thank you guys so much. It's, I love talking about this topic and about our program. So I'll be at FMEC in October. We actually have a huge cohort from Maine, Dartmouth coming. I'm doing a session with one of my colleagues about like a prenatal timeline exercise we're doing. Someone else is talking about opiate use disorder in pregnancy, which we do a lot of as well. So there'll be a lot of us there.
Great. Well, thank you so much, Dr. Lefebvre, and thank you everybody for joining. We'll let you get back to your evening, but if you have any questions, you got her email, and you can also reach out to FMEC. So thanks, everyone. Have a great night.
Thank you. All right.
Thank
Take
you.
care, everybody.